Thank you, Rebecca. Thank you for the introduction and welcome everyone. We are delighted to have you here today for the first panel of the conference, where our distinguished panelists will discuss the challenges in the COVID-19 vaccine research, recruitment, and testing. So I am very pleased to introduce our first speaker, Dr. Molly Klote. She is the director of the Office of Research Protections, Policy and Education in the Office of Research and Development at the Veterans Health Administration. She joined the VHA 2 years ago after 30 years of service in the Army. Her final job as a colonel in the Surgeon General's office was overseeing policy and compliance for all human research. She holds a board certification in allergy immunology, and her dream is to build trust with communities of color and underrepresented populations so that they participate in medical research that addresses their own communities directly. She will be followed by Florencia Gonzalez and Megan Ware. Florencia Gonzalez is the co-director of the Inclusion of Diverse Populations Core under the Georgetown Howard University's Center for Clinical and Translational Science. She also serves as community liaison for the center's Community Engagement Core. She leads efforts to establish community academic partnerships for inclusion of underrepresented groups in research. She supports investigators in the implementation of community and patient engagement best practices. She has prior experience managing clinical trials and overseeing disparity health research within community settings. Additionally, she has a history of grassroots field experience conducting case management with immigrant populations and managing public health projects in cross-cultural settings such as Sub-Saharan Africa and Honduras. Last but not least, Megan Ware is the Study and Peer Support Coordinator at Howard University Vaccine Trials. She serves as the lead recruiter for the Novavax Phase 3 vaccine trial. In addition, she is a peer support specialist for the STI-SPNS project at Howard University Center of Infectious Diseases Management and Research Clinic. She specializes on quality assurance and enjoys providing necessary insight on healthcare improvements to ensure patients are provided with quality services. She has prior experience in customer service, which has offered her rich opportunities for leadership, personal growth, and a passion to make a difference. So welcome to our three panelists, and thank you so much for joining us. Our panelists are going to talk for 15 minutes about their experience. And as you listen to them talk, please feel free to engage and type questions in the Q&A feature as they occur to you, and we will present them to the panelists at the end of their presentations. So without further ado, I'll hand things over to Dr. Klote.
So good morning, everybody, and I am delighted to be here representing the Department of Veterans Affairs in this conference. So great start off talk on what the sort of the landscape is of what's going on, and I want to talk about what VA's role has been and how we worked with increasing diversity into our trials. Next slide, please. I did want to start off, though, with just giving sort of an overview for those who might not be familiar with sort of the breadth of the VA. We are the largest integrated healthcare system in the United States. We've got more than 1,200 healthcare facilities, 170 medical centers. In those medical centers, 104 of them have robust research programs. We have 9 million veterans enrolled in our healthcare system, with 6 million of them coming in for visits within the past 12 months. Next slide, please. So the VA has been at the forefront of research, including multi-site research in the United States. We have the infrastructure to oversee large-scale national trials, and we've done that. And we did this as part of the federal response to COVID, known as Operation Warp Speed. We partnered with the other federal agencies and industry in bringing these trials and enrolling veterans into these trials in communities all across the United States. We have a unified electronic health record, which is unique and provides a rich data source for research, for our researchers and for those who choose to partner with us. Next slide, please. So, you know, your tax dollars pay for the research that goes on within the VA. And so what do you get for this? The graphic that I've got up right now is really our COVID response. So this was just within 12 months, and the different circles mean there were more than a certain number of studies happening at those. But as you can see, our COVID response pretty much went all across the United States. But we don't just take care of COVID, you know, we have every healthcare problem that you can imagine that any veteran could come up with, as in addition to a lot of unique healthcare issues with exposures that happen uniquely to military population. So, but we do have this national platform. We are partnered with hundreds of academic medical centers across the country. And more than 70% of all medical providers in the United States come through a VA at some time during their training. So get some sort of exposure to the VA. So, you know, really proud of the enormity of the mission that we have in VA. Next slide, please. So these are just some of the, you know, selected out research success stories that have come out of using the VA's platform, you know, implantable pacemakers in the 50s to hypertensive medication, comparative effectiveness trials in the 70s to rolling out the shingles vaccine trial in the early 2010s. The new VA DECA arm, you know, was a big prosthetic success. And then but we do other types of research like skin cancer research, and we have diabetes research and precision oncology research, and you know, just about any type of research you can imagine, it's being conducted within the VA. Next slide, please. So our Chief Research and Development Officer, Dr. Rachel Ramoni, when she first got to the VA 4 years ago, established the first 3 priorities that you see there on the slide. And in last October, added these 2 new priorities for us, which was to promote diversity, equity, and inclusion within our sphere of influence. And we specifically targeted it and used that language in particular. I mean, we can't fix diversity, equity, and inclusion everywhere, but we can in what we touch. And that's what we're really focused on. And then building community, which is trying to do more outreach, trying to figure out how we return some sort of benefit for those who participate in our research studies. Next slide, please. So as part of this initiative under Dr. Ramoni, we created the Diversity and Inclusion Advisory Subcommittee to the National Research Advisory Committee to the Secretary of VA. And this really esteemed panel from across different offices within the VA, and next slide will show you who they are. We're partnering with them, and you can go to the next slide. We're partnering with them to look at how we can get the word out and how we can better partner with all of the different programs that already exist within the VA and engage with them to get the word out. So we have our faith-based initiatives. We have our tribal and intergovernmental affairs group, the chaplains that again get back with the faith-based groups. We have a women's group. We have homeless programs. We have, and we're partnering with the COVIPN, which was another group that was instrumental in getting the COVID trials up and running in the United States. So next slide, please. So our outreach program is centered on what the previous speaker touched on, which is this broken trust that has happened within, you know, the history of research. And the goal of this program is really to talk about how research protections have changed and grown, over these past 30 years. As most of you know, we didn't have a national common rule, which is the basis for how we conduct research in the United States until 1991. And so a lot of the atrocities that have happened before that. There's still problems in research that occur, and we want to be open with that. Transparency is got to be our new keyword to rebuilding and reconnecting trust. Next slide, please. So the human research protections plans that are established in each of our VA medical centers that have a research program really are like a stool, where you have the federal rules, you have the local policies, you have the written plan, and you have your IRB. That is that ethics review panel. But we also have to have the researcher and the support of the institution to make sure that the whole program works. Next slide, please. And then unique to the VA, not unique to research in general, because there is the Office of Human Research Protections, but unique to the VA, we have the Office of Research Oversight. This is a group of dedicated professionals who go out and assess risk to participants and risk to the agency, and they do compliance visits, both on site and during the pandemic. We're doing them virtually, but they are a network. And at every medical center that has a research program in VA, there is a research compliance officer who reports directly to the medical center director. Next slide, please. So another part of our outreach program, and actually it's also our inReach program, is this idea that words really do matter. And, we have for many years saying we're going to research on this particular community, right? And we're trying to change that and say we're researching in the community, we're researching with the community, and we're trying to make that culture change. We're also trying to change away from the word subject and move toward the word participant or volunteer as just a matter of trying to better partner with our communities and, again, build that trust. Next slide. So how we responded to some degree in our diversity efforts was we realized very quickly that our normal outreach program wasn't going to work. Just putting up flyers in the medical center, having providers talk to people wasn't going to do it to get people into the COVID trials at the speed that we needed them. So we created a research volunteer list. And within 7 weeks, 58,000 veterans signed up to participate in these COVID-19 trials. Now, not everyone was eligible, but what it did for us is we got names and all the normal demographic information, but we also got ages and we got ethnic information and racial information on people, so that when the drug company said, okay, we're shutting off all white participation, and we're just solely going to Black and African American and Hispanic or Latinx, we were able to very quickly shift and redirect our call center to reach out to these people and get them alerted that they could participate. Now, not everyone who even showed up to participate was eligible to participate, because we didn't do it wasn't a screening tool for the studies. It was just literally a volunteer list. So, but it was something very new for the VA that we stood up very quickly, and we're very proud of, and we're very proud of the veterans who stepped up and volunteered. Next slide, please. But that the diversity in our registry, and we're now at 58,000 volunteers. We had 56,000 at the time this slide was made, but 23% came from our minority or underserved populations, and 18% were women, which is pretty reflective of the population of those who come to the VA for their care. But we had public service announcements done. We had print and digital media where we could. We got our Black and Hispanic veterans to volunteer to be in photos and participate in these outreach opportunities. Next slide, please. So I also want to talk about the Million Veteran Program. So MVP is the largest collection of genomic data in the United States. We have over, it started about 12 years ago. Over 831,000 veterans have volunteered through March of 2021. It's the largest African-American cohort of any genetics program, we think, in the world. And the MVP's goal is to have 1 million veterans enrolled by the year 2022. I've put in just a graphic of what the breakout of our the races are that are represented. And we're always looking to increase the diversity into the MVP. Next slide, please. So this, last month was the Women's History Month, and we had a big focus on women's veterans. We had more than 1,000 new women veterans sign up for the MVP last month, with a goal by the end of this fiscal year, so by October, to have 5,000 more women enrolled into the Million Veteran Program. Because while the VA has about 18% of our population are women, only about 9% in the MVP are represented. So, and we know that there are 2 million women veterans out there. So they don't have to be beneficiaries of the VA to enroll in MVP. They just need to have served on active duty at some point. Next slide, please. So those are, some of our outward facing efforts for what we're doing. But because we're really trying to target our sphere of influence, we are a funding agency as well. We fund about $800 million worth of research as an intramural program within the VA. And so we started to take a hard look at, who are we funding, and are we being fair in our funding? And so we're starting we started collecting baseline data of, are our minority and underrepresented researchers being given the same opportunities to perform research, and then monitor that success over time. And the success is in the programs that we're putting into place. And so we're looking to, how can we assist our minority and underserved researchers in having a better shot at getting funding? And so grant writing is a big key to that. And so we held a seminar last month. We did a big survey of writing needs. Is it just grants? Is it abstracts, manuscripts, presentations? How can we help them, improve their visibility within our community? Because we really believe that if we can break this idea that, government research is bad or is, out to get you, that we will be able to affect future generations of people wanting to become researchers and wanting to participate in researchers. And with that, I think that's the end of my time. And I just thank you very much for this opportunity.
I believe that is my cue. Hello, my name is Florencia Gonzalez, and I'm co-director of Inclusion of Diverse Populations Core for the Georgetown Howard University Center for Clinical and Translational Sciences. And Megan and myself, we will be talking about our experience with recruitment of diverse populations for the Novavax trial at Howard University. And I'll pass it on to Megan. Next slide, please.
So I will start off giving a little background about the COVID vaccine trial at Howard University. Howard University was selected as a site for the Novavax phase 3 vaccine trial by the National COVID Prevention Network. And just a little background about Novavax. It's a biotech company located in Rockville, Maryland. It became the 5th company to launch a phase 3 trial in the United States. And the study at Howard, it's the phase 3 trial, placebo-controlled, and it was initiated to evaluate the safety, efficacy, and immunogenicity of the Novavax vaccine. Next slide, please. So the trial was led by Howard's very own Dr. Sihan Majoo. She's the assistant professor in the Howard University College of Medicine, and she's an attending physician in the infectious division of the Howard University Hospital Department of Medicine. She's also the medical director for the Center for Infectious Disease Management of Research Clinic, and she's the principal investigator for the COVID-19 vaccine trial at Howard and has played a very instrumental role during this COVID-19 pandemic. Next slide, please. So I believe Florencia will present the collaborations and study team.
Thank you, Megan. It took a collaborative effort among various Howard University departments and centers to make this study a success. This list includes departments and centers that contributed to the implementation of the study. And I'd like to point out a few key players. Staff from various GHUCCTS cores, such as those listed here, help lead administrative, regulatory, trial operations, community engagement in partnership with SIDMAR. GHUCCTS offered key resources to ensure the COVID vaccine trial was launched and implemented. A community advisory board known as the CAB formed part of the study team, which included African American and Hispanic leaders. The CAB provided critical guidance to the study team on cultural and linguistic appropriateness of the engagement and recruitment efforts. They also connected us to community events for study promotion. The staff working at the Howard University Clinical Research Unit were where the study participants were seen and had been followed up, worked tirelessly to ensure good care for study participants. The trial truly would not have been a success without all these players. Next slide, please.
So just a little bit overview of the trial. The Novavax vaccine trial, it conducted their phase 1 and phase 2 trials in Australia and South Africa. The phase 3 trial was done in the United Kingdom before it was launched in America. The results for all of these trials demonstrated a clinical efficacy of over 90%. And the phase 3 trial launched in America was expected to enroll up to 30,000 volunteers across 119 sites. So that was 111 in the United States, 6 in Mexico, and 2 in Puerto Rico. There was an inclusion and exclusion criteria in the trial, and it was in order to help prevent or help provide evidence that the vaccine could be safe and effective in full range for patients likely exposed to COVID-19 and at high risk of hospitalization. If the participants were considered eligible, that means that they passed the in-person screening at Howard University's Clinical Research Unit, and they would be offered the vaccination. So the vaccination, it was distributed at a 2-to-1 ratio of randomization. And the way that I love to explain it to the participants was, just say 9 participants came into the clinical research unit, 6 would receive the Novavax vaccine and 3 would receive the placebo. All participants in the trial did remain blinded up until now, which is our crossover, but it's in order to preserve the ability to assess the vaccine's efficacy. The vaccinations, there's a first dose and a second dose. They're 21 days apart, and the participants are closely monitored for 7 days to see if they have any reaction to the vaccine, and they're followed up over 2 years through daily e-diaries and also through follow-up visits in order to monitor their safety and durability of the vaccine. Next slide, please. So just a little background about Howard University's recruitment priority groups. There were several recruitment priority groups, but just a few adults aged 18 and older, people from racial and ethnic backgrounds that were impacted in greater numbers by the pandemic, those likely exposed to COVID-19, those that had an increased chance of exposure at their job, those that lived or worked in elderly care facilities, those over the age of 65, those that also worked in jails and in prison. And the sites were asked to enroll 15% Black or African American participants, 20% Hispanic participants, and 1 to 2% American Indian, Alaska Native Hawaiian participants. Next slide, please. So the study received FDA approval on December 27, 2020. And as mentioned before, Novavax goal was to enroll 30,000 adults 18 and above in the United States. The accrual was expected to be completed around February the 16th. And the Howard site actually started December 28th, 2020, and enrolled up until February 11th of 2021. The original enrollment period was 8 weeks. Unfortunately, the sponsor did decrease it to 6 weeks, and we had to enroll within 5 weeks. But we did enroll 150 participants. The target was originally 300, and out of the 150 participants, 56% participants were enrolled from diverse ethnic and racial backgrounds. And out of that, 30 were Black or African American, and 21% were Latinos. Next slide, please.
So I think the following slides is where Megan and I will really get into the meat of and in the heart of our presentation. We wanted to share our approaches to recruitment, and not only recruitment, but to engagement, to the way we communicated with the participants and the way we engaged with our CAB members, and how supportive they were and instrumental in guiding us through the process of ensuring we were reaching the most vulnerable and the most needed populations. So we're very grateful to our CAB for their support. So the CAB was established prior to study recruitment. The members helped us identify locations for dissemination of study promotional material and provided input on the cultural and linguistic appropriateness of recruitment material. They guided our overall process of engagement with the community. The CAB included 4 leaders from the African American community and 4 from the Hispanic community. They were identified through our existing Howard University partnerships and through our existing GHUCCTS Community Advisory Board. In fact, 2 of our GHUCCTS Community Advisory Board members, Yanita Cruz and Abel Nunez, joined the study CAB as they felt this effort was very important for their community. Our study CAB members allowed us to distribute information about the study during events like food distribution sites, such as Kingdom Fellowship Church food drive and Pennsylvania Avenue Baptist Church food drives. In these kinds of events, you don't have a lot of time to engage with participants, but it did allow us to go out and share information about our study with a community that was most impacted by by COVID. And one thing I'd like to highlight about our outreach efforts is that we really got our team, our leadership, to go out and join these events, which is critical, I think, for engagement, is for the community to see the principal investigators and the leadership of trials. We had in the picture, in the slide, you'll see Dr. Carl Thompson, co-investigator of the Novavax vaccine trial at Howard. He's a microbiologist. And Carla Williams, who is community engagement director for GHUCCTS. And there's another team member whom I cannot distinguish, but we're very grateful that they were able to go out and share information about the trial. Dr. Melman also, who leads GHUCCTS at Howard, went out and participated in these events. And it was really an opportunity to engage with the community and to really just understand what, in what ways we could share information, not only about the trial, but provide educational information about COVID prevention as well. So another approach to recruitment was through presentations during educational webinars or town hall meetings. Some of these events were in partnership with our study CAB members. Though we sought to promote the study through these events, we felt it was important to provide information about clinical trials, vaccine trials, as well as address vaccine hesitancy through education. The purposes of our webinars was not solely to promote the study, and it should never be solely to promote the study when you are working with the community. And this is in line with following best practices around community engagement. So we were very cognizant of that fact, and we wanted to make sure that we were providing the necessary information. We were addressing questions that the community had through our webinars and our town hall events. We conducted over 10 webinars throughout, in partnership with community organizations or those we led throughout late 2020 and early 2021, and we're still conducting trials. And we really involved our principal investigators in this process. In fact, investigators who had never presented to a community audience also got a lot out of this process, allowing them to feel more connected to the community and practice presenting in lay language, which can be very challenging. And we had to practice beforehand with some of the more technical presentations about the mechanisms of how a vaccine works, which can get very technical. So our investigators did a phenomenal job in modifying their the way they approach the information, and so kudos to them. I would like to share a really, I think for me, was a very powerful video. One of our community leaders is very, very vocal about his concerns regarding vaccine hesitancy among the African American community. Reverend Matthew Watley from Kingdom Fellowship shared information about the Novavax trial through a video he put together with one of his media partners. And this was intended for the African American community to address vaccine hesitancy. We'd like to show you a few minutes of this video.
We know that the longer people go without the vaccines, the more people will be infected. The more people that are infected, the more African Americans will die disproportionately. And so literally waiting equals more Black people dying from COVID.
Hey there, how are you? Just fine, thanks. All right. I'm privileged, I feel privileged, quite frankly, to be able to do a very small part to help to beat COVID, recognizing the need to demonstrate the vaccine safety for all people, but particularly for African American community that has good reason to have skepticism because of the so many instances historically and currently of medical racism, where we are not given the same treatment.
Reverend Matthew Watley is a volunteer participant in the Novavax vaccine trial. He's using his influence to change the narrative about vaccines among the Black community, where misinformation has circulated about vaccines and scientific fact is at times replaced with conspiracy.
The worst conspiracy would be for us to be dying the fastest and being willing to take the vaccines the least.
Black Americans are nearly 4 times more likely to be hospitalized from COVID-19 and 3 times more likely to die from coronavirus.
Can you, can you continue with the presentation, with the video?
Yes, 1 second.
Thank you. It ends where he goes up the steps.
I'm sorry, there seems to be some technical difficulties with
Oh, no problem. I just think his messaging is so important and good for us to all hear.
I'll just refresh it 1 second.
Longer people go without the vaccine.
It's inevitable. We're doing Zoom. It's bound to happen.
I just want to make sure we're starting back
Okay.
in the right spot. So, all right, here we go. I'll start it back up.
About the vaccine or COVID?
I've had any number of conversations about the vaccine, both in our congregation and the community and my own family. Many of my own family members start off with, and it was always the same sort of list of issues. The general distrust because of a real history of medical racism that African Americans were saying either, no, I'm not going to take it, or I'm going to take a very long wait and see approach.
Reverend Watley began.
Okay, so that gives you, you know, he did this on his own. We just, he showed up with the cameras at Howard, and we had really, you know, it caught us by pleasant surprise, and you know, we're very grateful that he is sharing the message to the community about vaccine hesitancy. And so the point here is that when working, our CAB members were really invested because they cared very much about how disproportionately COVID was affecting the African American and Hispanic community, and the time and investment that they've committed to providing guidance to us and meeting with us formally through our CAB meetings, but also ad hoc in order to discuss more specific issues such as translation, the proper translation, cultural linguistic competence, appropriateness of our flyers. You know, they just were available and ready to support this effort in any way possible. Next slide, please.
So I agree with Florencia. Oh, can you go back actually? Thank you. I agree with Florencia. Reverend Watley is extremely phenomenal and so humble throughout the entire process. I actually recruited him, and not once did he identify that he was a pastor and he was planning on recruiting his congregation. So preceding to that, I actually recruited him through the registry, which was a very helpful recruitment strategy for both Florencia and I. We had the ability to prioritize volunteers of racial and ethnic backgrounds based off of their risk of exposure, hospitalization, location, and demographics. We also worked closely with the Howard University communications team to develop and publish a press release, and that can actually be found on Howard University's newsroom, which is located on our website. And we did not solely have that press release to recruit, but it was to get the information out to the community that was mostly impacted by COVID-19. And from that, we learned that sharing clinical contacts is very, very important when recruiting the Black and Brown community, and explaining to them what their benefit is to get vaccinated is extremely important. Word of mouth was key, and I found it to work like a domino effect. It really just helped the recruitment process happen more naturally. And I found that the more participants I recruited, whether it was through the registry or they called either I or Florencia's direct line, the more comfortable they were in recruiting their friends and their family. We also had advertisements broadcasted on Radio Zul and WHR, and we really focused on promoting the vaccine trial with culturally appropriateness in mind. The advertisements I found to be very helpful in recruiting defined demographics and getting the word out to the community most at risk. We did find that on the registry, some of the participants, they didn't have the highest risk of exposure based off of their occupation and several other factors, but we found with the radio, it spoke out to the entire community. And listeners, they were ensured that the vaccine, number one, would not give them COVID, it wouldn't change their DNA, it wouldn't make them a guinea pig. Rather, it meant that they were playing an important role in finding a vaccine to end the coronavirus pandemic. Next slide, please. So I found that allowing for meaningful engagement during the screening process was extremely successful. As a recruiter, I learned very, 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 very quickly that getting people to give you their time can be extremely hard. So that was my approach, to allow for meaningful engagement. The more human and personal the interactions were, I found that participants were much more engaged and interested to join the trial. With the rapid change of technology due to the pandemic, I knew it was becoming harder and harder to get a live operator on the line. And I know that just based off of my own experience. And my goal throughout the recruitment period was to speak to everyone that called and deliver convenience, empathy in each interaction, and create a safe space for participants to express their concerns and their fears. The start of the trial, because it was the very end of December, many participants feared how COVID-19 could affect them because it wasn't the vaccine wasn't readily available for all Americans. So I recall some of my first conversations with the participants. Some of them were hesitant. And one conversation I will never forget, one participant, she opened up to me about her fears going back to work, her 18-year-old daughter's fears of not having a prom or a graduation, her concerns not being able to see her parents, and essentially fears that this pandemic could extend way into 2022. She felt hopeless. And she wanted to participate in this research to be the change that she wanted to see. And from speaking to her and the other participants down the line, I learned that they all had a different story. No one story was alike, and all of them had different motives for wanting to participate in the trial. I found the more hesitant participants were about getting vaccinated, the more important it was for me to share my story. So I actually got the Pfizer vaccine at the beginning of January, and that's when people weren't too sure what the side effects would be. I would get all types of questions. What type of adverse events will I have? Will I get Bell's palsy? Will the vaccine affect my fertility? What symptoms will I fear? And to answer all of those questions, I would share my story about getting vaccinated. I would tell them about my process from start to finish, the basics. I signed a one-page document asking about my demographic information, my medical history. I got vaccinated. I waited 15 minutes and I would sit on my way. I would then ask the participants if that process would be enough for them to feel safe and assured. And if they answered no, then I would imply that maybe this vaccine trial may be for them. And I found that emphasizing to participants that they would be closely monitored and they wouldn't be sent on their way, it made them feel much more comfortable in participating in the trial and trusting Howard to keep them safe. I also found that no matter if a participant was indecisive or decisive about participating in the trial, it was important for me to encourage them to do what was best for them. I would ensure that their safety was what was most important to the Howard vaccine trial team. And a lot of times I would give the participants time to think, what's in it for me? And I think that's really important because if someone can think what's in it for me, they can make the best decision for themselves. Lastly, I would take the time to share educational information about the clinical trials, and that was found on the Howard clinical trial website, and that was with the help of Florencia. The website's actually titled, Let's Talk About Clinical Research. And I would also send them the most recent Novavax vaccine information. And I found that keeping the participants informed helped them make the best choice for themselves. Next slide, please. So I would say that the Coronavirus Prevention Network Screening Registry was the most successful strategy. And there is a picture of the main screen you would see when you log in. I think it was most successful because it funneled in most of the participants. However, I do feel like all of our recruitment strategies work together to make this strategy successful, because from flyers to press release to CAB members directing their participants to the registry, it all directed them to the registry. And together, all of those strategies helped enroll 97 participants just from the registry alone. Next slide, please.
Okay, so I'd like to talk a little bit about our strategies for inclusion of people with limited English proficiency. We were very cognizant that we had to provide quality language access through written documents and through the ability to have a bilingual person available to participants who did not speak English. And because the study is very involved, it's a 2-year study with anywhere from 8 to 10 visits. We also needed to be aware of what languages we had access to in order to be able to allow individuals to get quality language access. So for instance, Spanish being the most common language in the area, and the focus on recruiting Hispanics because they're were also very vulnerable in getting COVID. We focused on Spanish. We sorry, I could belabor this, but there's a lot involved here. And it's not that we didn't want to include other languages. It's just that we had to make sure that and this goes back to ethical considerations around language. We had to make sure that a person that spoke, let's say, Amharic or French, needed to be available in the middle of the night if there was an emergency. And so those are the kinds of considerations we needed to take into account. With that said, we did have trained interpreters that were trained in the consent process, trained about the protocol, and trained about just how the study flowed in order to make sure that interpreter was qualified to convey the exact information that was conveyed in English into Spanish. Now here is where we are also very grateful to our CAB, because our CAB was instrumental in identifying an interpreter for us. Unfortunately, because of the demand of interpreters at the hospital, we didn't have access to the hospital interpreters in the way we needed them. These visits were long, and our hospital interpreters there wasn't the capacity. So we were very lucky to have our CAB members basically share their staff, their bilingual staff, with us, and be ready to come and interpret when needed. The sponsor did provide translated documents and flyers and consent forms, though we had our CAB members review them for cultural and linguistic appropriateness, and we did make modifications accordingly. One thing to note, which is really important working with the Latino population, is the consideration of undocumented individuals, the potential of recruiting, of not providing barriers to recruitment of individuals with that aren't documented. A lot of times they were the most vulnerable because they're living in crowded conditions. The jobs they have may require that they have interaction with individuals throughout the day. And so we needed to make sure that we informed the Latino community that immigration status, social security number, and financial information, that kind of information was not going to be asked at any point during the study process. Next slide, please. Okay, so Megan shared her interaction with participants. I'd like to share a little bit about my interaction with the Spanish-speaking participants, and most of whom in my interactions knew very little about clinical research. So it was very important that I took the time to explain about clinical research, explain what placebo was, what randomization was. And so you've got to keep in mind that you've got to give yourself time to be able to provide that kind of education. You can't really rush through these conversations. And also, it's critical to understand their life context. Is the study a right fit given their life context? For example, I was speaking to a gentleman who was in a Hub Grub, I believe it's called, Hub Grub driver. He delivered food from restaurants to people. And so that was that was how he made his living. Any time he takes off from doing that is lost to his income. And so we had conversations about that, and they then could make a decision about whether they could participate in the trial, as I would share what the time commitment would be throughout the 2 years and the different visits that they had to come to. Next slide.
So now that the vaccine trial is way into being a trial for months, we have done a lot to have to retain our participants. And I think what has been a very successful strategy for us is being transparent and, most importantly, culturally having culturally appropriate communication to keep the participants enrolled in the study. The vaccine trial, I think that they do a really good job at educating our participants in ways that they're going to understand. And I think that Florencia, she did a really good job at explaining to you some of the services she's had to provide when it comes to cultural interpretation. And I think that that in itself has retained many of our Latino participants because it's assisted them in completing consent form, having different medical discussions, and she's provided that service over the phone, remote, in person to make it convenient for them. Would you like to add anything to that, Florencia?
Health literacy is key, and gauging where a participant is in terms of their health literacy is critical, and then adapting accordingly the information, what you share with them. And what I mean by adapting is how you communicate to the person the information. Are you going to need to simplify and explain further, or do you are they understanding the information, the consent form, and then they don't have any questions, and then you sort of, so you let that, you gauge first where they are with their health literacy, and then you act accordingly to that.
Yes. Also, I feel like now that our participants are living a life of going back to work because things are slowly going back to normal, the Howard vaccine trial has had to take the time to meet the participants halfway. That whether that's rescheduling a participant or allowing them to seek additional monitoring. I feel like we do a really good job at working with their schedules and making sure that we're responsive to their needs to ensure that they stay safe in the study and enjoy the process. Another retention strategy I believe we've been using is we've offered our unblinded participants the opportunity to stay in the trial. And to unblind means that, they've withdrew from the trial, and that could be for several different reasons, but the most popular one so far is the concurrent rollout of EUA vaccines. For the participants that have withdrew due to receiving the EUA vaccines, they are offered a follow-up option to stay remotely connected with our trial team for safety every 90 days during the first year of participation and 108 days the second year. And that is because Howard University, we're dedicated to educate and ensure safety of all communities of racial, ethical, and cultural backgrounds, no matter what the circumstances.
So Megan, it sounds like reading a chat that the next panel begins at 11:40, and I think we have about 7 minutes for Q&A.
Okay.
So Mariel, could you help us with those questions? I think you're on mute. You're on mute, Mariel.
Yes, thank you, Florencia, and thank you, Dr. Klote and Megan, for fantastic presentations and for sharing your experiences. So we have only a few minutes to go over some Q&A. We have several already. So the first one is for Dr. Klote, and the first question is, how did the VA experience the pandemic from the treatment side?
Right, so I did answer a couple of the questions. I typed in some answers to questions to just, because I didn't know how much time we'd have and I wanted to make sure people got their answers. But from the treatment side, like the rest of the country, I mean, the VA is representative of the country in many ways, although we have a much older population. And so, the average veteran or the average person in our population is about age 65. And so the older populations were at risk. And so From a treatment side, we took a lot of aggressive measures to do screening before people came into our medical centers. We reduced anybody who didn't need to be in the medical center from being in the medical center, but kept all clinical, the life-saving services open and available to our veterans. But we had the same things. Our ICUs were full, just like pretty much everybody else in the country for a period of time.
All right. So one of the questions I think was regarding how the VA gets involved with different sponsors. So what is the best way for external sponsors of research to connect with the VA?
So we heard loud and clear from all kinds of partners that the VA was hard to partner with because we have so many ways to enter into the VA, through 104 different medical centers, through meeting people at conferences, whatever. So last year we created the Partnered Research Program Office. That is the best way to get into the VA. And if you search VA Partnered Research Program, you will find the pathway to partner with VA.
Okay. So, and what are the plans for the VA registry now that the COVID vaccine trials are completed?
Yeah, so we're going to expand the registry. I mean, we were so successful with this registry that we're looking to expand it to other disease processes. We're in the process of talking about it right now, about how do we open it up, put it on a larger platform, and actually staff it appropriately, since we sort of shoestringed it through the pandemic.
Wonderful. Excellent. We have another question, I think, for Megan or Florencia. So what about the participants who didn't have access to computers or smartphones? How were they able to interact or recruit?
So that's where that's why we did the radio spots, because we understood that technically the media savvy or the computer savvy people were probably the ones that were in the registry, and the radio spots allowed us to reach a broader community. And we provided a phone number, not a link.
All right.
For a bilingual line.
And then I'll also like to add that those that actually are participating in the study and don't have access to a smartphone have been provided a smartphone through the vaccine trial to complete their e-diaries daily.
All right, thank you. Thank you. We have another question for Megan. It says, great presentation. Can you talk a little bit how the ban was used and if it was successful?
Megan, do you want me to take that, as I had planned to talk about that?
All right.
Yeah, so I'll just be very brief about the van, but we plan to use it, and we plan to launch it into areas where with the most needed, most vulnerable communities. Unfortunately, we weren't able to use it. One, because this trial was shortened, and it was shortened because recruitment was going really fast at the national and international level. And secondly, there were some challenges with, and I want to be careful what I say here, but there were some challenges at the sponsor level where there were questions about whether the van would be equipped to handle the sensitivity of the vaccines. And so, though we had sites in mind that the CAB helped identify, those were some of the challenges that did not allow us to launch the van.
Right. We also heard from Dr. Dimer that they were not able to go out with the mobile van to recruit participants for the Moderna trial. Wonderful. So Megan and Florencia, are you learning if research outreach to your study geolocations, neighborhoods, wards, SIP areas outperforms comparable areas for community engagement and uptake or full vaccination? As cases continue to occur, does the research seed planted overcome hesitancy?
I'm not sure I'm understanding the question. Are your learning and research outcomes? I'm sorry, I'm not sure I'm understanding. As cases continue, does the research seed planted overcome?
We're going to wait to see if she can explain a little bit better.
Are they able to say the question, or can they only chat?
Yes, they can chat.
Okay.
another question for both of you. Do you use Research March database as well?
Not that I know of. I'm not sure we promoted through Research Match.
Okay.
Yeah, there was a registry already through the CoVPN, and so I think it was already a focused registry for anyone interested, and so we just stuck to this focused registry.
All right. Dr. Klote, what are the VA perspectives on guidelines and regulations to improve diversity in government-funded and industry-funded research?
Yeah, so we don't have any control, obviously, over industry-funded research. Certainly, we're going to help our minority and underserved researchers develop their grant writing skills so they can go after those industry grants, they can go after those NIH grants, DoD grants, you know, and other nonprofits. But within the VA, we certainly have control over who we fund. Now, we have to fund things that have the highest scientific merit and have the most applicability to our veteran population. But certainly we can do a better job of ensuring that, you know, the playing field is level.
All right, thank you. We have another question in the chat. In your experience with clinical trials, is there usually time built in for active listening and health vaccine education in clinical trials that aren't working as hard to reach underserved populations? I think they mean about other clinical trials that are not COVID-19 vaccine.
I mean, I'll tell you that from our experience with the COVID, you know, areas that were stood up, there was a lot of crosswalking people who showed up to get vaccinated, got walked down to other clinics to say, you know, their blood pressure's high, you know, as they got screened into it. So there was some primary care connections that were made from people who were volunteering into the research trials.
All right. And I have another question just to finish with this. Were the lessons learned from this study and for the experience, are they going to translate elsewhere, or are there challenges and strategies, the strategies need to be different for each clinical trial? Or do you think that all the lessons that you have learned with this can be translated to every clinical trial?
I'll just briefly provide my input. I think that so many of the lessons learned can be transferable to any clinical trial, including carving out the time to listen, to have those conversations with your participants when they're considering becoming a volunteer. So yes, that I think is one of the most transferable ones. And just working with the community advisors and leaders who can inform your the appropriateness of your recruitment material. I think any community advisory board or patient advisory board can only enhance any clinical trial.
All right.
Agree.
Okay. Thank you very much. That's all the time we have. Thank you so much to my panelists for sharing your thoughts and expertise, and to our audience for your attendance and engagement. Now I will hand things over to Dr. Mary Schmidl, who is the Senior Director of the Office of Research Oversight at Georgetown University. I apologize, Mary, for going over. Thank you.
Thank you.
Thank you, Marielle.
Thank you so much.